myself organized here. Thank you very much. I want to thank the Canadian Academy of Health Sciences for inviting me to talk today. It is a daunting honor. Tony Phillips yesterday made the case that scientific directors at CIHR are actually expected to be involved in science. And it's not very often, actually, that I do get to talk about my science. And so I'm very, very pleased to have this opportunity today. I cannot forego the opportunity to also talk about gender, obviously. And so a major thrust of my presentation today is going to be about why gender matters, in particular to public health. But I'm also, hopefully, for those of you who don't do public health work, I'm going to make the case that actually both gender and sex matter to all research. And these are issues that we need to be thinking about very carefully. I really enjoyed Dr. Cashman's presentation, and I just want to point to one small example that he gave that I think actually makes the case for why gender matters to public health, and that is the example of Kuru. We see in that example why gender matters in terms of propensity for disease, that it was the women and the children who were most vulnerable. I think that actually really does make the case about why we need to think about particular populations and why gender structures, indeed, influence opportunities for all of us. So today, I want to talk a little bit about public health the perspective that I take in relation to public health is that it really is action-oriented. It's focused on solving pressing health issues. And public health interventions involve programs, interventions and policies that really are directed at improving the health of populations. I've also become very interested in knowledge translation, and not surprisingly, that's a key area of interest for CIHR as well. And I think Cam Wilde yesterday made some really important points about knowledge translations and its limitations. But I think if we rethink a knowledge translation as this dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge, I think that it really does point the way that we actually do need to be thinking about ways to actually convince policymakers and others about the need to change and to take up sound practices. In my presentation today, you're going to hear echoes of some of the talks from yesterday because indeed a lot of my interest has been in the field of addictions and mental health. So many years ago, actually about 20 years ago, the question was asked in a great textbook, why are some people healthy and others not? And this actually launched us into a really good discussion in Canada to think about the health of Canadians and to think about the determinants of health. And many of you have heard this talk before, and I just want to remind you about some of the key messages from that text. And one of the key messages in my mind was related to what really accounts for the variance in health outcomes. Healthcare certainly is important, and it certainly is a preoccupation of Canada in terms of health outcomes. The behavior of the population is also very important for us to think about. Genetics are also important, but actually fairly small piece of the pie in terms of health outcomes. But it's this blue sector, the social conditions that actually really do matter in terms of influencing health outcomes of populations. And we often don't think that much about what sits in that blue section and how we can influence it. So under this blue section are a number of factors that we refer to as the social determinants of health. And you can read a variety of documents that outline the social determinants of health, and they include such things as income, education, unemployment, early child development, food insecurity, etc. And numbered amongst that list is gender. And what really strikes me is so often gender is not really thought about as a social determinant of health. A lot of our public health efforts really do indeed focus on issues related to income, employment, and other issues such as race and disability. And we don't think about gender to the degree that we should. I think that is beginning to be corrected, and indeed, the report of the Chief Public Health Officer of Canada 2 years ago focused on gender and made the case that gender does matter, and we need to be thinking about it in terms of health outcomes. It's interesting. I want to say a few more words about gender before I turn to my specific work. So here are a few examples about why gender matters, and I want you to think about it as a structural factor. So in social science, when we talk about a structural factor, we're talking about norms, values, kind of the unwritten rules that really influence what we do and what our opportunities are. So here we have a picture of, actually I Googled, and I encourage you to do this, I encourage you to Google man food. What's so interesting is that the marketers actually really do understand this. And so we think about social structures and how indeed they influence what we eat, what is seen as appropriate for a man to eat, what is seen as challenging for a man to eat. And we can laugh about that, but indeed I have colleagues, male colleagues, who tell me they would never order a salad at lunch when they were out for dinner with their male friends. These are social structures that influence our health opportunities, influence our decision making. Next to the man who's eating a rather large hamburger is a picture of a woman eating yogurt. And if you were to think about women's food, yogurt often comes to mind. I don't think you can actually see an advertisement on television today that features a man eating yogurt. Indeed, it tends to be thought of as women's food. The marketers understand this, and indeed we are influenced by these social structures. I'm making fun of this in a way, but I think it's really important for us to understand the ways in which we are influenced by these broad social structures. We can also think about this in relation to our opportunities and the roles that we take on in society as well. So down on the left-hand side, we see the typical Rosie the Riveter taking on what was thought of as a male role. This was deemed to be appropriate during a particular period of time, but as soon as the men came back from war, that role was no longer appropriate. These are gendered structures, and you might indeed think that this is no longer the case today, but it is. We think about the wage gap in Canada, we think about the roles that women and men continue to take on, and gender still is at play. It's influencing our opportunities, it's influencing our health outcomes. Down in the right-hand corner, we see He Can Do It. It's a man holding a baby and also a dustpan. And indeed, recently in the Globe and Mail, there was a piece about how Beckham was caring for his children, and it was referred to as, quote, babysitting. And why is it then when a man takes care of his children that it is considered babysitting instead of fathering? These are social structures that influence opportunities, expectations for all of us. So in my work, I'm making the case that gender matters. We need to think about it in terms of our healthcare practices. We need to think about gender in terms of how it shapes opportunities and outcomes. So you might be asking yourself, okay, what is gender? And I'm going to make a distinction between gender and sex. So gender refers to the socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and gender diverse people. I add gender diverse people here because there are a lot of people who are no longer wanting to fit into our predetermined categories of men and women. It influences how people perceive themselves, each other, and how they act and interact, and also the distribution of power and resources in society. So gender is powerful in terms of outcomes. We make a distinction between gender and sex in some ways because it helps us move to hypotheses and to understand the causal mechanisms of how gender and sex might influence particular outcomes. So whereas gender we think of as a social construct that influences opportunities, we think of sex as biological. It refers to a set of biological attributes in humans and animals. It is primarily associated with physical and physiological features, including sex chromosomes, gene expression, hormone levels and function, and reproductive and sexual anatomy. I think it is important to make this distinction because so often in our work we actually just report on the basis of sex, we talk about differences, and we don't really think about. So we'll say, well, cardiovascular disease, there's a difference between men and women in terms of their outcomes, but what is the mechanism underlying that difference? Is it physiological or is it social? We need to push our thinking further and to think about mechanisms in a more refined way. Indeed, I was very pleased to hear Neil Cashman talk today. I finally do understand, I think, protein misfolding. But I also interacted with Neil very recently at a consortium meeting related to neurodegeneration and aging. And it was pointed out, and rightly so, that 70% of people with Alzheimer's disease are women at the present time, and we actually do not understand the mechanisms, the causal mechanisms underlying why women are considered to be particularly vulnerable. And indeed, the international organizers of the meeting, or the international panel at the meeting, said, I think this is actually an area that we should be proceeding with and really thinking about. It could actually move our thinking forward. So with those definitions in mind, I'm going to move to talk a little bit about some of the challenges and also 3 studies that I've been involved in. I think that indeed there's a lot of popular myths and misconceptions about both sex and gender and their relationships to health. We think it's an area that everybody's an expert in. We think we know a lot. But there are also very important disparities in terms of outcomes for men and women in this country. You can turn to almost any condition, and we see really important differences in outcomes. And I think it's important for us to start to pay attention to this in a better way. So I'm going to give you a petit goût, a little taste of 3 studies that I've been involved in, and try to make the case how gender has helped to influence my work. So the first case that I want to talk about is work that we've been doing on frequent marijuana use. It's interesting. It was so nice to spend time with Roy Cameron over the last day because I actually began a lot of my work in the area of tobacco and studying youth and tobacco use. And one day, a bunch of teenagers said to us, why are you studying tobacco? It's so hard to get. Study marijuana. It's much easier for us to access. And I thought, oh, that's actually quite insightful. And so we started actually moving our work to look at marijuana use. And so we started actually, we had survey data from 8,225 students in British Columbia. And we giggled about British Columbia yesterday a little bit, BC Bud, et cetera. But prevalence rates of marijuana are fairly high in BC. So we surveyed students from grades 7 to 12, and we'd asked them primarily about tobacco, but we also included questions about cannabis, about marijuana. And this was really a beginning understanding of differences in use between boys and girls. So we began by, first of all, taking a look at this data and compared never users, frequent users, and heavy users. And I guess the first most startling thing is that actually boys use at a much higher rate than girls do. I think this is really important to pay attention to. We didn't really talk about this that much yesterday, but there are very different patterns of use in terms of drugs in this country. And the question is it sex or is it gender? Is it the response to the drug or is it these social conditions? And I think in part it's a little bit of both. So we learned that male heavy cannabis users, and at this time we were referring to heavy users as youth who reported using 10 times in the last 30 days. And they were more likely to be in grade 9 or higher, so slightly older, report poor economic status, never feel like an outsider. So these boys actually felt they were part of the social group. And they had lower satisfaction with family, friends, and school compared to boys that never used. And in comparison, female heavy users were more likely to be in a higher grade, report poor economic status as well, also report poor mental health and academic performance and have a lower satisfaction with their school compared with female never users. So we wanted to tease out these differences. There's different kind of a different kind of phenotype you could think about in terms of heavy use among the boys and girls. So one of the things that we often do when we want to try and understand phenomena in more detail is we go in and we spend a lot of time in communities and hang out with kids and find out what really is going on. So the evidence really does suggest that, and I want to just give a little shout out to those poor children who put their pictures up on Facebook, etc. These are the photos that are going to haunt all of us into our futures. But the evidence does suggest that frequent marijuana use among teens can lead to academic difficulties, social isolation, and mental health problems. And, you know, yesterday in the debate we talked a lot about marijuana, the legalization of marijuana. I think we all recognize smoking marijuana is not a good thing for young people to do, particularly if they're doing it very frequently. So we went into 3 communities and we were really interested in applying a gender lens to our drug research. And Anderson argues that applying a gender lens to drug research asks us to study substance use more carefully and to recognize the impact of social and cultural constructions of masculinity and femininity on individual and group drug use. So that's what we're interested in doing. So as I mentioned, we went into 3 communities in British Columbia. This was referred to as the TRACE project, and it still continues today. We're moving into more of a KT phase, and I'll tell you a bit about that. So we did ethnographic research. We spent hours in these 3 communities. We talked to adults in the communities, to police, to teachers, to parents. And then we conducted detailed interviews with over 80 young men and women who indicated that they used marijuana frequently. So this was actually young people who were using more than once a day, many of them 4 or 5 times a day. They were smoking first thing when they got up in the morning. They were smoking during the breaks. They were smoking after school. And our interviews focused on history and patterns of use, the potential benefits and consequences of marijuana use, and connections between smoking and aspects of identity relationships in place. I can't tell you the whole story today, obviously, but I want to just pull out a few things related to gender in particular. So here's a quote, and this is actually, again, remember I talked about how certain food becomes man food. It's interesting how certain drugs become boy drugs. So marijuana is a guy thing. Yeah, I've never seen a chick, one of them, be a stoner. For some reason, I have a lot of trouble seeing a girl smoking pot. I mean, it seems to be more of a guy thing to me. I mean, I know it's not, but well, I mean, maybe it is more of a guy thing. But I know the girls do it and stuff, but I have trouble seeing it that way, I guess. We heard this similar type of quotation many, many times. And so you can see social construction of gender influencing practices. And I think this is really important for us to understand if we're going to actually develop better public health interventions. The girls also said similar things to us, and here's a quote about girls and marijuana use. I think guys do it more to get high and girls do it more to fit in. I think I don't know that for sure, but that's my perception because you see a lot of the preppy girls up at school smoking pot, and they just shouldn't smoke pot. Like they don't inhale it. This is a sin. It just doesn't look right. It's not that right type of person. So again, we see gendered norms at play in terms of marijuana use, in terms of who uses and who doesn't. And so when we probed this data even more, we actually saw really important differences in terms of the ways girls and boys use marijuana. So what we learned is that girls actually are more likely to smoke marijuana alone. They are more likely to smoke marijuana to cope with emotional difficulties, be they personal difficulties or difficulties they're experiencing with their families. And boys, on the other hand, are more likely to entrench their marijuana use in social practices, skateboarding, hanging out with other boys. So they tend to do it more in groups. What was interesting to us, though, is that despite gender, both boys and girls lacked opportunities to discuss their marijuana use. It was really the first time that they had an opportunity to talk about why they were using, the choices that they were making. And I think in some ways this liminal space that marijuana sits in, it's an illicit drug that their parents use, that their friends use all the time, but it can't be talked about in the school context, creates a lot of difficulty. We've brought these findings back to the school districts that we've been working with, and we're now moving into a knowledge translation type of project where we're trying to encourage a discussion about decision-making among young girls and boys related to marijuana use. So we've actually developed a film. It's an interactive film that pauses and asks questions. You put yourself in the shoes of this boy or girl and helps you think about how decisions should be made in relation to marijuana. So we're developing a curriculum around this material, and we're moving it out into the school district over the next few years, trying to, I guess, shift the discussion, move us away from thinking only about talking about reasons for not doing it, but encouraging a discussion about the reasons for use and the reasons for choosing not to use as well. And so imbued in this KT initiative is very much a gender sensitivity, an understanding that there may indeed be different reasons for why girls and boys use, and we want to explicitly explore that. I'm going to move on to another project that I've worked on, and this is a project that actually has completed, and we heard a little bit yesterday about harm reduction related to inhalation drugs, and this was a project that was funded by Health Canada before, when there still was a harm reduction program in this country. And this was a project focused on crack cocaine. We heard yesterday a lot about how indeed harm reduction has incredible value in terms of health outcomes, but the information around inhalation is quite limited. A lot of our focus has been on things like needle exchange, but even in the city of Vancouver, actually, crack cocaine is the drug of choice. We see a lot more, we see heavier cocaine use, crack cocaine use, than we do heroin use, for example. And those who are using crack cocaine were saying kind of, what about us? How can we actually minimize the harms in relation to our own use? So this was a project involved with a number of public health workers and partners in Vancouver called the SCORE Project, Safer Crack Use Outreach and Education. Again, we were really interested in the gendered nature of drug use, and as I've already mentioned, the experience of drug use is shaped by both formal, these are the laws, and informal social controls, rituals, and transmission of knowledge. You learn to be a drug user. You learn by observing others, by taking up practices of others. You're influenced by others. And crack use practices are no exception to that. And indeed, they're highly gendered. Women are often disadvantaged in many ways. They often do not have their own equipment to use. They're often, quote, second on the pipe, and they often cannot obtain their own supply of crack. They depend on others for that supply. And women who use crack cocaine are often forced to engage in sex work in order to support their own use and that of their partner. Prevalence of crack cocaine use in Canada is unknown. As I mentioned, it's commonly used, and women, what we do know is that women do tend to report higher rates of use than men. So we were really interested in this social context. What's really going on? How could we develop and think about a harm reduction initiative related to crack cocaine use? We surveyed a small group of crack cocaine users, 97 users of crack cocaine, and most of the respondents indicated in this survey that they did indeed engage in unsafe crack use practices and experienced harmful consequences associated with crack use. They were sharing their equipment, they were engaging in harmful practices. One of those harmful practices is the use of Brillo in the pipe that often disintegrates and gets inhaled in a burning form. And other practices, for example, using pipes that often are at risk of exploding and causing burns and cuts. So of those surveyed, there was an acknowledgement of interest in actually trying to think about harm reduction, and so we thought we would move forward and think about what might be done in this area. So we set out to understand, as I mentioned, the social context of crack cocaine use and to begin to develop some harm reduction programming. And we did this in partnership with drug users in Vancouver's downtown east side. We learned from the HIV/AIDS epidemic the motto of nothing about us without us, and I think this is really very, very important in terms of public health programming as well, that we don't engage in this type of work without really understanding the needs of the population. And so actually, with the help of over 200 women who were drug users, we set out to assemble and eventually disseminate safer crack kits. And so we actually saw the kit making itself as an intervention. These were kind of the quilting bees of the modern day time. In the old days, women had an opportunity to get together and quilt, for example, but we got together and put together harm reduction kits. And so these, over the course of several months, we created a space where women could come together, share their experiences, and, quote, take a break from the constant vigilance that was required on the street to protect themselves and others. And our goal, actually, in doing that work was to really learn from women in their own words about the harm reduction programming. As we started to move forward and distribute through peers these harm reduction materials, we thought it was really important to understand the dynamics. And while the kits were being distributed to all users, men and women, we really felt it was important to be quite gender sensitive in the way in which we proceeded. So we actually assembled 14,000 harm reduction kits and distributed these kits through peer interactions. And I think that the evidence that we collected suggested that participating in harm reduction work, such as kit making, did reinforce a positive sense of self-esteem in these women's abilities to contribute to harm reduction in their own neighborhood. And we often don't think about the agency of drug users themselves and how they actually could be contributing in positive ways to their own contexts. So again, just very briefly, after 1 year, we did actually go back and did another cross-sectional survey to try and get a bit of a glimpse of what was happening in relation to crack cocaine use. And we did see some. We certainly didn't see a lot of modification, but we saw some modification of practices. There were still some sharing practices at play. Most participants reported that they had shared a mouthpiece or a pipe with people that they knew, and over a third had shared mouthpieces and pipes with people they didn't know. But one noteworthy change, and I think a real sea change, was an increase in the number of people who indicated that they preferred to use a mouthpiece. And since that time, Vancouver Coastal has actually started to distribute mouthpieces. We've seen the uptake of harm reduction initiatives in Vancouver in relation to crack cocaine, and I think that's very, very encouraging. And I think it was really important for this work to kind of take a gendered take on it. I think it improved the delivery, it improved the outcome, and also I think it improved the process. Often when we think about gender, we only think about women, which is interesting. And as I like to point out, men have genders too. And so it's really important in terms of thinking about gender and health outcomes that we do also pay attention to outcomes in relation specifically to men. And so with a colleague, the third example I want to give today is work that I've been doing with Dr. John Olaf, another nurse at the University of British Columbia, and really I would say a foremost expert in the area of masculinities and men's health. And this is work that we've been doing in the area of men and depression. It's interesting in terms of what we know about depression. We know that depression is a leading cause of disease burden, and women are reported to be twice as likely to be diagnosed with depression. The symptoms of depression include sadness, loss of interest, feelings of guilt, sleep disturbance, appetite change, and lack of energy. And it's interesting how little we actually do know about the causal mechanisms of depression. There's quite a bit of debate in the literature about that. Pfizer, this is their quote on their site, depression may be related to the imbalance of natural chemicals between the nerve cells in the brain. But there's a lot we don't know, and a lot that we need to understand more about. It's interesting because there is a bit of a paradox in relation to depression. Women are 2.5 times more likely to be prescribed antidepressants than men, but men and boys are significantly more likely to commit suicide than women and girls. And we don't really understand what is this dynamic all about. Is it sex? Is it gender? What's the dynamic? How can we more fully understand this? It's interesting because I think we have to really also probe how our methods have shaped what is known. So actually a lot of measures that we use in research have now been seen to be gendered biased. So I want to explain that a little bit. One of the commonly used measures of depression in research is the CESD. I've used it myself. And there are 2 items on that scale. One asks about how often you've had crying spells, and the other asks how often, whether you are indeed talking less. Crying and talking are gendered practices. We know that, for example, women actually learn to cry more. It's considered more socially appropriate. We also know that women tend to engage in more pro-social behavior. And so when we ask men and women these items, despite having underlying similar levels of depression, men will respond differently to those items than women. This is a problem with our measures. We need to step back and think about this in terms of the way that we're actually capturing depression. There's also some evidence that the way that clinicians recognize and diagnose depression is biased. So clinicians are more likely to see women as depressed when they're not, and might also not recognize depression in men. And I think that's the other piece that we need to be paying attention to and thinking about. So with my work with John Olaf, we've been trying to understand men and depression in a new way. And this again has been qualitative work. We've done a series of qualitative studies focused on men and depression and have interviewed college men and then also middle-aged men and their partners. And John's also done work with older men and depression. And I think the findings from this work actually are really quite telling. I think that masculinities, or what are the gendered kind of norms in society, indeed do influence men's ability to express their depression and to actually to talk about it, and also the symptoms that they indeed experience. So what it means to be a man really does mediate these experiences of depression. So the ways in which men embody depression are quite different. The way they talk about their symptoms are quite different. They talk about anger, isolation, and risky self-care practices. Drug use, alcohol use, other risk-taking. Anger is very, very prevalent. And it's interesting because John would argue, and I would agree, that a lot of these types of symptom expressions can be read as expressions of masculine ideals. This is the way you should behave. This is an appropriate way to express these types of symptoms. And I know that's a different way for us to think about this, but I think that if we're going to really get a hold of depression and an understanding of symptoms, we need to kind of step back a little bit. So here's a quote. I like to use quotes because I think it's really important to bring in the voices of those who are affected by different conditions. And this is a 37-year-old man who was diagnosed with depression. When you have an outspoken voice on the TV saying, "I suffer from depression," it makes it that much easier for women to come forward and say, "Yeah, I also suffer from it." But you don't you don't see like Arnold Schwarzenegger coming up saying, "Yeah, I do suffer from depression," right? You don't see that, and you never will. So here's, I think, a really beautiful example of how really a hypermasculine ideal does not really fit with depression. And so where are our role models? How do we begin to think about what depression is? So where's this work taking us? I think that it's really pushing us to think about new ways of recognizing depression in men. I think that we're trying to move forward to think about ways that we might screen in new ways. I think it's also pushing us to think about new understandings of how gender relations shape depression, and these gender constructs shape the expression of depression. And also, I think it's really pushing us to rethink possibilities for screening and treatment approaches that might be more gender sensitive. It's interesting because in Australia there's a large men's health initiative that's taking place, focused a lot on the issue of men and depression. And they're really, for example, from a public health standpoint, really pushing us to think about opportunities for men in our society, to engage socially, and thinking about some of the protective factors that might be put in place. The program that they've initiated is called a SHED program, but the Men's SHED program is immensely popular in Australia. And sheds are places where men hang out, they share tools, they talk about their work, they engage in hobbies, and the Australian government has invested heavily in this as a way to actually engage in a public health initiative that might address the issue of men and depression and health outcomes in their society. And I think, that's one practice in another country, but it's a practice that we also can learn from. So, I'm almost done. Public health issues are very important for us to think about in relation to gender. I cannot think of a single public health issue where that gender does not touch. And so when we engage in public health practices, when we think about developing our research initiatives, when we think about our clinical practices as well, I think that we really do need to think about gender, about how it affects our interactions with our clients, with the public, and how these social structures indeed influence opportunities. So I encourage you to think about this. Think about your science in a new way. Think about your interactions with your clients, with your students, and think about how these gendered structures might indeed be influencing their opportunities. I think there is a climate of change and opportunity. I think the conversation is changing. I think that considering sex and gender really can be a source of innovation for us. We could actually push through a number of issues if we took this seriously. So, thank you very much.